Okay, welcome everyone. Welcome to today's webinar on family-centered treatment model, the final webinar in our summer series on evidence-based practices. I'm Sheila Weber, the Director of Strategic Initiatives at Lutheran Services in America. And as the Director of Strategic Initiatives, I lead our Children, Youth, and Family Community of Practice, as well as our Results Innovation Lab. LSA is hosting this summer series on evidence-based practices for two key reasons. First, we have a vision of improving equitable outcomes for all children, youth, and families in the United States. One very important way of doing that is providing our network with additional tools to do so, such as expanding the use of evidence-based practices. Second, we want to prepare our network to be strong and actively engaged partners in your state's implementation of the Family First Act. The use of evidence-based practices as prevention services to help keep families intact and avoid children entering the foster care system is an important aspect of the Family First Act. And being aware of and able to actively decide if you are interested in providing various evidence-based practices is important so that you can engage your state child welfare directors in conversation around how services can evolve in your communities and the role that your organization wants to play. So before we begin, just a couple of housekeeping items. We are recording today's webinar, so all participants are currently muted. You are able to unmute yourself and ask questions during the Q&A segments. If you need assistance or have a question during the course of the webinar and you're not able to unmute yourself or you're concerned that it's not a good time to unmute, feel free to use the chat feature and I will keep track of your questions or answer your questions if it's a technical issue, or ask the presenters the question for you. Following the webinar, you will receive an email with a link to access the recording and any accompanying handouts. You can feel free to use that link to share with others in your organization who missed the presentation, or with your state child welfare or juvenile justice partners who you are considering partnering with to provide this service. Also, as an added bonus, you are able to receive free NBCC CEUs from Family Centered Treatment for attending today's webinar. And if you would like the NBCC CEUs, that's a lot of letters there, sorry, please put your name and email address in the chat box and I will share them with FCT so that they can email you your CEU certificate. Next, just to kind of give you a general overview, family-centered treatment is an evidence-based and research-supported trauma treatment model of home-based family therapy. And I want to welcome Tim Wood, Executive Director, Janet Fuller Holden, Operations Director, and John McDuffie, Program Consultation Director from the Family Centered Treatment Foundation, in addition to our members from LSS of Wisconsin and Upper Michigan, who will be sharing their experience implementing this model with you today. Tim and everyone with FCT and LSS of Wisconsin, who are Ann and Emily, thank you so much for joining us today and sharing this valuable information with our network. And I will turn it over to you, Tim. Tim, I need you to unmute. There you go.
Going back to the phone. Can you all hear me okay? It switched back over on me.
Yes, we can hear you fine.
It's a little faint, okay, but we can hear you.
No problem. I'll speak up again. It switched back on me last minute. Anyway, I'd like to say thank you to everybody for having us. Sheila, appreciate you setting this up. And I want to say a special thank you to Emily and Ann from LSS in Wisconsin for joining us too. Whenever we ask some of our partners and collaborators to join us in public speaking, we usually get a little bit of a sideways eye, but they've been troopers in joining us in this process. So if we could jump to the next slide. Today, we're going to try and cover a lot of ground pretty quickly. We're going to try and give some higher level overview of the background about the family-centered treatment model, stressing some of the importance of the emphasis we at the FCT Foundation put into the actual implementation process of the clinical model, since we see that as hand in hand. You can have the best clinical model, but if your implementation process isn't up to snuff with your clinical model, you're going to tend to not get the outcomes that you're trying to achieve. We'll take a look at some national outcomes as well as some LSS specific outcomes in their first year of implementation with FCT. And then towards the end, we'll just cover some of the broader national initiatives and some of the many pilot projects we have going on across the country. And then hopefully save some Q&A time for for folks who might have questions about any aspect of it. So a brief overview of who we are at the FCT Foundation. We are a 501c3 nonprofit, which is a little bit unique from some of the other third-party purveyors who oversee the administration of different evidence-based models. A little bit of a background in history. The FCT model's origins started in around the late 80s, about 1988. And through the 1990s and the early 2000s, it was really developed into the clinical model and research model that it is today. Initially in the 90s and 2000s, however, it was owned by a private company whose focus was on providing intensive home-based services to families in need. In around 2008, when the owner of the private company made a decision that he was going to be retiring and stepping down as owner of that company, he gifted the rights and training of the FCT model to the Family Centered Treatment Foundation, which is that non-for-profit company that we're representing. And his goal in gifting that process was that he wanted to be able to share the training and evidence-based model to companies who might not otherwise be able to afford the administration and implementation of models such as our own, seeing as though the training and implementation can be quite costly to providers. So it was through his generosity that he decided that he would like to be able to make the model more widely available to different providers in different states. So the responsibility for the FCT Foundation of the actual clinical model is for us to advance the training, certification, and innovation to different companies throughout the country. We have a variety of different types of companies that we license to, from private companies to nonprofits, and then recently our venture into working with different state entities, such as different counties, such as we do in Wisconsin, whose internal DHS systems actually are the ones who are hiring therapists to train through their program and implement in those particular areas. We're obviously also responsible for the overall licensing and sustainability of the model. It's our task and charge to ensure that the many different providers across the country are able to follow the FCT model to fidelity as it's researched. And we do that through our data collection process and continuous consultation and oversight. We also facilitate research for the model. We do not do the actual direct research of the model, but we work with different university and foundation and endowment partners to assist us with generating independent research to continue the advancement of the FCT model. And then finally, stakeholder education and model innovation. We're continuously refining the model based on practitioner feedback about what's working, what's not working with families that are being served, understanding the different needs that are happening and trying to be predictive of what is happening with the families that we're serving across the country. And then finally, we are also responsible for a number of different purveyor services and projects, such as utilizing some specific carve-out grants with different providers in the country, not necessarily doing the family-centered treatment model, but who need individual consultation on certain clinical aspects of the programs that they're trying to implement. So currently, we have licensed providers who are implementing FCT in 11 different states. Those are highlighted in blue on the map below, and that's spread across 20 different organizations. The states highlighted in green on this map are states where there is funding and anticipated streams of funding and providers that we are expecting to come on within the next year or so across the country. So we are excited to be in a pretty good growth mode right now with how we're able to reach different families in different states. We have statewide implementation, meaning we're able to cover the entire part of that particular state in Maryland, Rhode Island, Massachusetts, Indiana, and North Carolina, with various providers that are able to access services for families in any part of those states. And providers traditionally fund the provision of the FCT model through either Medicaid services or federal grant funding, or state and local grant contracts or awards. And then some states have been utilizing 4E funding and are looking to be doing transitioning to Family First funding when those states start to implement within the next couple of years. I highlight shared risk on here too, as that's been a big topic for us in a couple of different states, with one state going full board ahead with doing shared risk pilots with the providers. And it's been a really unique way to develop different funding streams for models, and it's been very attractive to different managed care companies and different funders in those states. And then finally, funding for implementation of the FCT models occurs through self-pay by the providers funding the actual implementation. Some states do assist with particular grant funding or state-sponsored trainings for the model. So I like to start off when giving some background in history by asking those who are on the call or those who are hearing the presentation to reflect for just a moment that if you could select and choose to do anything with the populations that you're currently serving, what is it exactly that you would elect to keep and do? What type of population would you like to serve? Are there existing parts of the clinical process that you think are attractive that you'd like to keep? Are there parts that you don't think are particularly effective and perhaps you wouldn't continue to do, but maybe you are required to do as part of a fidelity to a particular clinical process? And we asked this question and we put that out there because the origins for the family-centered treatment model are a little bit different than some of the other comparable models that we work with, in that FCT was not initially theorized in a university or hospital setting and then put into field practice. Instead, it was a practitioner-developed model, meaning that in the late 80s, in the 1990s, the model originated out of practitioners coming together who were just starting to do in-home type services, and it was relatively in its infancy at that point, and saying, here's what we know is actually effective in working with models for family preservation or reunification, and here's what's not actually working. From those series of meetings, from that continued development, what happened was the conglomeration of those ideas, those best practices, and all of the work that was being done by the practitioners and putting it into a structured model. And from there, it was out and field tested in the early 2000s to determine its efficacy. And hence we have the clinical model, which is now the family-centered treatment model. The theoretical framework for the model has been refined over the last 20 years, but some of the important and key structural pieces that have always been ingrained and that we have been working with in collaboration with different experts throughout the years has always remained within the model. Salvador Minuchin's development and consultation through his eco-structural family approach, and those who are doing the FCT model will always comment on how they see his fingerprints kind of on how we look at a structural perspective and a systemic perspective when trying to view the family as our client, as well as Sue Johnson's work with emotionally focused therapy. Attachment theory, attachment understanding is a really integral part for us to determine what are the underlying functions of behavior that are affecting this family and not allowing them to function optimally. And so through her consultation, through her work as part of EFT, we've been able to embed a lot of very sound attachment-based ideas and concepts into the FCT model that have allowed us to really address the underlying needs for families and helped us get some real sustainable changes with those families. And then finally, over the last 5 to 6 years, we've been working with the National Child Trauma Stress Network and Dr. Richard Kagan, who's helped us implement a number of trauma treatment best practices into the FCT model. It was an integral part in us being able to be identified on the National Child Trauma Stress Network listing as a trauma treatment model, as well as becoming a network member and network partner with the NCTSN.
All right, Tim, thanks. Well done on kicking us off. I'm John McDuffie, and I'm a program consultation director. I get to work with LSS of Wisconsin and Upper Michigan, Emily and Ann, who will be presenting some information to you a little bit later. But I get to talk about the clinical model and take a little bit of a deeper dive into how it works and some of its foundational elements. So this simple Venn diagram really represents the most common case profile that we see in FCT today. sometimes these issues are on the forefront of the case and sometimes on the periphery or in the family's history. Either way, they present and exert influence over the family system. And one unique aspect of FCT is that it is a systemic model, meaning that we believe that it's important to simultaneously maintain the integrity of the model as it's designed and be flexible and encourage the blending of other approaches into the model through a structured vetting process. In other words, we want to be able to account for local population needs and emerging social issues, such as the opioid epidemic. And MI, motivational interviewing, trauma-focused CBT, ART, substance use treatment, and as Tim was talking earlier about emotionally focused therapy, or EFT, are a few examples of other approaches that can be woven into the fabric of FCT to account for specific population, clinical programming needs, or emerging social and psychological issues that continue to evolve and families have to navigate. So given the complexity and acuity of this population, and given the myriad of models and approaches that are out there, why take a family-centered approach? Well, we believe in the unbridled potential of the family to solve problems, heal wounds, and meet high expectations, as reflected in some of these quotes that you see here. Some smart people from various perspectives think similarly. So just as most of the problems faced by our families have their origins in the family, we also believe that the solution resides within the family system as well. And this is due to the power of attachment bonds to overcome whatever the family is experiencing. So the broad stroke of FCT is that we focus on the repair, creation, or accentuation of the attachment bonds in combination with a value integration approach, as opposed to a behavioral compliance approach to promote healing and to drive sustainable results. And we'll get into that idea of value integration a little bit later. So another question that we like to ask is, what is meant by sustainable change? FCT was designed to bring about sustained change, and we do this through creating value integration, not behavioral compliance. As we guide a family through the phases of FCT, we do not look for behavioral compliance as that's insufficient. Instead, we drive toward value integration, helping the family discover or reconnect to their own family values and guide them through a process of aligning their patterns of behavior and interaction with their value system. So at the end of the day, the goals the family identifies and the new behaviors to reach their goals must make sense to the family in order for the gains they make in treatment to be sustained, or to generate the motivation needed to overcome what is sometimes generations of pattern behavior that have become very strong through that muscle memory. So the 5 pillars of family-centered treatment were created very early in the development of the model, and they represent the foundational paradigm of FCT. And you could sort of think of this as the values of FCT, meaning everything we do, from how we interact with the family, the interventions we use in session, to how we speak about our families and team and with stakeholders, must be congruent with the pillars. So if we were to take dignity and respect, one way that we operationalize dignity and respect is through setting high expectations with the family. Often, and that might sound a little counterintuitive, but oftentimes behaving toward the family, the clinicians behaving toward the family with those high expectations is a new experience for the families. These are often families that exist within a narrative of learned helplessness, and this narrative is often promoted from within and from outside the family. However, if we believe in the family's capacity for change and setting expectations that match those capacities, communicate to the family that they are capable of greatness. We also believe in honoring the function of behavior. In other words, we're not chasing symptoms. We're really looking to explore and help the family understand why things are happening the way they're happening, why people are behaving or feeling the way that they're feeling. We believe the importance that treatment must be relevant and useful. And I'll get into an example of that a little bit later. We also believe in the importance of internalization over compliance. And again, I'll tease that out in just a moment. And then lastly, the power of giving. And I'll give an example of that as well as we progress through the model. So on the very first session with families, we put the pillars in action by making a promise to the family in the form of the FCT guarantees. So every clinician is required to communicate and describe and discuss with the family these guarantees on the very first session. And it's the family, the FCT team, and the supervisor's responsibility to ensure that the FCT clinicians are living up to these promises in each and every interaction they have with the family and with stakeholders. So some of the ways that these things play out is the first two, I think, are pretty straightforward. We simply believe in being kind and direct. So one tenet that we teach early in FCT with a new organization is the idea that you should never leave a family's home without communicating exactly what you're thinking or what you're feeling within professional boundaries, of course, so that we create a very transparent and a very honest process. And we had that discussion with families very early on of how can I best relay an idea or observation that you may not agree with or that you may not like. And we kind of worked that out and sort of set a tone very early on that your time and my time is way too precious to waste. And it's also, again, based on that belief that families are capable of hearing the truth or hearing our direct opinion on things, as long as it's delivered in a kind and direct way. Another one I want to tease out here is the promise to include you in any contacts with other agencies. So no closed door meetings. If it's an important case decision or content that needs to be discussed or reviewed, then it's our duty to include the caregivers in those conversations as a way to maintain our trust and to continually join with the family throughout the treatment process. So by now, it might be obvious that we place a really huge emphasis on engagement with an FCT. We are very deliberate in shaping this process with clinicians as they are learning FCT. And if we fail, this is based on the idea that if we fail to engage with the entire family, we'll never earn the family's trust. And without this trust, we will not have the foundation to push the family to reach their maximum potential in the later phases of treatment when we're actually starting to help them restructure the family system in accordance with their goals and with their values. So again, everything we do has to tie into the idea that it's a privilege and not a right to be in their home. And these are open communications that can really help in the joining process in the first or the second session to say, hey, look, I know under normal circumstances, our paths likely would not have crossed. And I've been asked to come into your home and to invade your home and your privacy. And that may or may not have been your idea, and you may or may not be really interested in me coming in here. And I just want you to let you know I take this with a lot of respect, and I look at it as a privilege to be with you, to learn about your family and to learn about how you want your family to be moving forward and how we can help you get everyone else kicked out of your life forever and reach that ideal family that you want to have. The other thing, actually, I'll get to that here in this next slide, which now we are going to go through and break down the 4 phases of family-centered treatment. So the typical length of treatment is 6 to 9 months, although the process is individualized for each family to attend to their specific needs, and the time frame can decrease or increase dependent upon that need. And what we like to do is, while we're going through all these details, of the 4 phases is to end with a one-word concept that best encapsulates everything of that particular phase. So starting off with joining an assessment. This is the first phase of treatment. It typically lasts 30 to 45 days. And the role of the clinician is to offer hope, earn the family's trust, learn what it's like to walk in this family's shoes per each individual family member through the implementation of experiential-based assessment activities. So one thing that is that we want to make clear for new clinicians and for them to make clear with families when they're first working with them is that this is not a I'm going to do to you type of treatment. This is we are going to do this together. So the purpose behind or the function behind the experiential assessment activities that we do in joining an assessment, which are very structured, is to help not only the clinician kind of see what's going on and begin to connect dots, but the family members themselves to be able to see what's going on in their family and start to connect dots. And as we're going, we are beginning to hone in or funnel down on what the core issues are, what the core family values are, and what behaviors or patterns need to change in order for this family to be living in accordance with their own value system. We also want to successfully reframe the problem away from just one individual, which is oftentimes the symptom bearer within the family system, and reframe it as a family problem, that the entire family is taking ownership of the issue or the problem that they're facing that led to the referral into the program, and therefore they all have a stake in the solution. And then lastly, we want to help the family articulate their specific goals for treatment. Because I think we can all agree that we're only going to work really hard on goals that we believe in and that we come up with. The trick for us as clinicians working with families is to align the goals that they come up with, that they themselves articulate organically through the phase 1 process with the goals of the referral source. So it's very rare that those goals are going to sound exactly the same, but if we can draw a reasonable, logical line between those two goals, then we've done the job. The emphasis or the wording will be different, but if the general target is pretty close, then we've done a good job with that. So the family learns to trust the process, to make that and to reframe this so that there's family ownership, and define those goals moving forward. Oh, and the one word that we like to use to summarize joining an assessment is trust. The second phase of treatment is restructuring, and this is the longest, most arduous phase of FCT. It can last anywhere from 2.5, 3, 4, 4.5, 5 months, depending on the complexity of the case. I should have mentioned earlier that oftentimes reunification cases take longer just simply because there's more moving parts. And sometimes it can take a little bit longer to reignite those attachment bonds between family members that they've been separated for a long period of time. But the restructuring process is where we take those goals that the family has articulated. We take everything that we and the family have learned about each other in joining an assessment, and we begin to implement practical, common sense strategies to address those problems and to reach their goals. The primary mechanism for change and restructuring and valuing change and generalization, the phases 2 through 4, are called enactments. And some of you may be very familiar with that, but it's basically based on the idea that talk is cheap. When you're looking at working through generational patterns of behavior, we not only have to, I should not say talk is cheap, I should say talk is insufficient, to work through those generational patterns of behaviors and oftentimes deep-seated intergenerational trauma effects as well. And therefore, what we ask the family to do is to practice in front of us new ways to handle those tasks of daily living where the symptoms of the family will show up. So getting the kid up in the morning, getting the 14-year-old up in the morning into school when there's a history of truancy, possibly being teased at school, or there's an undiagnosed learning disability. Of course, the kid's not gonna go. So, you know, we help the family practice new ways to go about handling those simple tasks of daily living. That is the point of intervention of SCT. The hard part is for clinicians to learn to let go of control of the session, to allow the family to interact as they normally do in front of us, and find opportunities to politely interrupt and then put on our director's cap and direct the family to tackle that situation differently. Oftentimes, a clinician will come with a pre-planned enactment based on their observations, and oftentimes in conjunction with the caregivers to implement with the family. We do a lot of experiential type of icebreakers to kind of get everyone up and moving around at the beginning of the session, and then really kind of dig into that practical intervention where we help the family learn new ways of behaving and interacting as a family. And in that process, we debrief and we review how is that different for you? What did you like about it? What did you not like about it? But more specifically, we get down to how that felt different, to be supported by your wife when she is disclosing something traumatic that happened into her past, as opposed to clamming up or running away or providing solutions, but simply being there and able to listen and to strengthen that attachment bond. How does that feel different than how you normally go about things? So that is a repetitive process that we have to be comfortable utilizing a trial and error approach. We will offer suggestions on how to do things differently, and sometimes that will work and sometimes it doesn't. If it works, we replicate that and do more and tackle more complex issues. If that enactment did not work, we learn from that, we discuss it, we own it, and then we adjust our strategies moving forward. And this is where the treatment intensity component of family-centered treatment is very important. Not only do we have a set of fidelity that Janet will speak to a little bit later, but we also have, we also need to provide FCT at a very intense level, 2-3 sessions a week, sometimes 4, sometimes 5, depending on the case. 5, 6, 7, 8 hours of direct face-to-face contact with the family per week in order to practice and capitalize on that trial and error approach so we begin to find the solutions that make the most sense to the family and that are effective. The one-word concept for restructuring is practice. It's practice, practice over and over again. Trial and error. We fail, we fall down, we learn from it, we pick ourselves back up, and we try again. That brings us to value and changes. So typically, in a lot of traditional models, treatment wraps up at the end of their version of restructuring. You've made behavioral changes, the family's doing better, they're making progress, or really have accomplished many, if not all, their goals. However, we believe in the need for a few additional steps. And phase 3, value and change, is designed to help the family take everything that they've learned in terms of these new skills and begin to own them and start to use them in novel ways or in novel situations. This is a very sensitive point in treatment where oftentimes families will regress. They become very ambivalent, oftentimes because now they know how difficult the change process is going to be and how much work is going to be necessary to create sustained change. And oftentimes those old patterns of behavior, the status quo, rears its head and becomes very comfortable for a family system. And we normalize that in FCT. We see that as a strength, and we have to be very tuned in to when we see that happening and help the family reframe as, okay, yeah, that makes sense. You are taking a really hard look. If you want to continue on with this new way, that's going to require a lot of hard work, or if you want to fall back into the comfortable old pattern, the status quo. That makes sense. What's she going to do? And we put the responsibility back on the family, and in restructuring, we're more of a coach, we're more of a director on a movie set. In value and change, we move into more of a cheerleader role, where we encourage the family, we help build their confidence to continue to make these hard changes for sustained growth and outcome. So that sometimes means we might get a little provocative. We've earned a lot of joining chips by the time we get to value and changes. So this might be where we spend some of those joining chips and really hold the family accountable for the direction in which they're going to go. However, the clinician must change their approach to be less directive and more supportive. We become a safety net, and we simply hold the mirror up for the family so they can make an informed decision of which direction they're going to go, which direction is consistent with the values that you have so clearly defined and have been working on for the past few months. Which direction are you going to lead your family? The one word concept that we use for value and change is internalization. And then lastly, generalization. Our one word concept or generalization is planning. And this is where we take everything that the family has learned in SCT and look ahead to the future of the events that are coming up in the family's life cycle and how they can apply what they've learned today and adapt what they've learned today to those future challenges. So it is based, this is all based on the belief that just because the family has gone through SCT doesn't mean they're not going to stumble, doesn't mean they're not going to have challenges from time to time. But the way we frame generalization for the family is, yeah, you're going to face these challenges like every family does. The difference is you're going to handle them much different. So the goal of SCT is not only to help the family treat the current problems that they face, but it's also to help them to predict and see the challenges that they will face in the future and how they can plan to tackle those problems as they occur based on what they've learned. So again, it's a lot of confidence building. It's a lot of strategizing and planning and thinking ahead about, okay, your 12-year-old is going to be 13, 14 over the next couple of years. What do we know about your older teenagers now that you're going to need to adapt and change the way that you interact with them? Or maybe it's a child that is on the verge of launching into adulthood. How are you going to go about changing that dynamic and that relationship to promote that launching and to resist that urge to want to keep the kids at the home, in your home? One aspect of SCT that I mentioned previously was treatment intensity. And I hope you guys can see this. It's a little bit faint, but there's a little bell curve now overlying the 4 phases. And that's to demonstrate a treatment intensity bell curve that we feel like works very well with SCT, in which we enter the family system respectfully and slowly to earn the family's trust and to not smother them very early on in the treatment process. That might look a little different to a family that's very much in crisis that needs a lot of boots on the ground. Then it may not look like this, but across the board, sort of in general, we believe that starting out that way and then gradually increasing our treatment intensity through the restructuring process where the family is breaking the status quo, they're trying out new ways of being a family. There will be some pushback by various members of the family to those changes. And therefore, that's when we want the boots on the ground to really help support that family and to be there when they need us most. And then as we move into value and changes, our treatment intensity begins to titrate down as the family is taking on more ownership. They're applying what they've learned to new situations. And we show up to sessions and we hear about all the things that they have done over the previous week on their own to address problems that previously would require a crisis call. And then lastly, and I'll speak a little bit more about this later, our systemic trauma treatment elements can be applied at any phase of treatment. They're very specifically applied from a diagnostic perspective in joining and assessment, but oftentimes because our joining and assessment phase digs so deep into individuals and families in the entire family system, oftentimes we uncover trauma that needs to be addressed right away. Of course, if a family member expresses readiness, or we help them get ready through joining and assessment to really address those issues more specifically and comprehensively in restructuring and value and change. The 6 areas of family functioning are progressively identified during phase 1. The areas are how we organize the family pattern of behaviors and interactions. Everything we do in treatment must line up with a primary area of family functioning in order to create coherent arc of treatment so that we stay focused and on target with goals and strategies. So I'm not going to go into all these today, but just know that these are sort of the behavioral categories, or where we would take patterns of behavior and kind of tuck them under, or set them within these 6 areas of family functioning. So by the end of joining assessment, we have a clear idea what area of family function is primary. And we also utilize the family assessment device, which is a self-report questionnaire document that all members of the family 12 years and older can complete, that also gives us some clarity and direction as it relates to the areas of family functioning. And also sets up a good way to do pre and post treatment effectiveness measures. So blending FCT with best practices, one way I'd like to highlight this is through an example of a very simple process that we like to do with families early in phase 1, which is to have the family member draw a simple clock, a circle with 1 through 12 written, or 12 through 11 written on the clock, and have them shade in the areas, the times that their family experiences the most conflict, or when the referring behaviors tend to be most prominent. And then the clinician commits to the family that this is when I want to be in your home, is during these times when conflict and stress are the highest. And that's how we make FCT, again, very practical and very relevant. The point of intervention is in those day-to-day, seemingly unimportant events that happen, which collectively form the family system and display or form the patterns of behavior that become entrenched over time. And that's exactly where we want to be boots on the ground and where we want to implement our interventions. So the trauma treatment component of family-centered treatment is largely influenced by emotionally focused therapy and attachment theory, particularly the inclusion of adult attachment theory. It's been our experience with the target population that's most served by FCT that oftentimes there are multiple generations of trauma. And now we have the family that we're treating in front of us where that is all manifesting in its various ways. So to summarize and sort of bottom line our trauma treatment approaches, we have very structured ways to diagnose and assess the type and degree of trauma that the family members individually and as a whole have experienced over time. And then we create a series of corrective emotional experiences, again, based on Sue Johnson's EFT model. As she beautifully articulates, the best therapist in the world can provide a lot of healing by creating safety and helping a person work through their trauma. However, if we can successfully restructure the family system so that the family members themselves are able to create that safety, are able to receive the narratives of past harm and hurt, and provide the empathy and the nurturing through the use of attachment bonds, they can have a profound and sustainable effect on trauma. I think the way Sue Johnson says is that she can hold a pin light on these issues where a spouse or a caregiver or a mother or a father can hold a stadium floodlight. So when a wife is able to hear her husband's story of war atrocities, he committed after suppressing those memories for years, because, if I were to express and disclose those things to anyone, I would be seen as a monster, and I would disgust my wife if she knew these things that I did, and she would leave me. But if we can work with both parties individually to prepare them to come together, it creates a corrective emotional experience with profound effect. The language that we use in FCT for trauma is emotional blocks. Actually, we use it to represent a continuum of emotions that can impede a individual or a family to reach their goals. So on one continuum, it simply might be, anger outbursts that consistently get in the way of staying calm and in control and disciplining the kids, all the way to an acute trauma that someone has experienced that causes a parent to freeze and when they're needing to perform their role as a caregiver or as a parent. This is a couple simple examples. So lastly, some distinctive features of SCT. It's not a client-centric model. We view the family as the client. And a lot of this we've already talked about, so I'm not going to go over it again. Just know that, that Janet's going to get into more detail about some of the other components aside from the clinical model itself that is necessary to implement and to train with an organization in order for the model to be successful. But a couple other things is we also believe that FCT organizations, or we require FCT organizations to adopt a non-exclusionary, no eject, no reject policy when it comes to accepting referrals. There are a few caveats to that. There needs to be an identified caregiver who is identified to play that role of caregiver. They don't necessarily have to be doing a good job at it, and they don't necessarily have to be super excited to do FCT, but that person simply must exist. So if there's a permanency plan is sort of all up in the air still due to various reasons, it may make sense to wait until that permanency plan is more established before making a referral to FCT. And then the other two major exclusionary criteria are acute psychiatric illness that requires immediate hospitalization, or acute substance use disorder that requires immediate inpatient care. Those two things need to be somewhat stabilized in order to come in and do intensive family system work. That being said, we work with a lot of families with a lot of substance use. We work with a lot of families with a lot of behavioral health issues, but if they're to that point of hospitalization or inpatient, they really need to be stabilized before they can participate in FCT. And so oftentimes that will happen. The referral will be made. They may go into inpatient or be hospitalized for a period of time and then come back more stable, and we're ready to go and implement FCT. The last thing I wanted to end on as it relates to the clinical model itself is in phase 3, we talk about this very early in phase 1, but in phase 3 is when the family implements what we call the family giving project. And this in a lot of ways is it's very demonstrative of where the family started to where they are today. And it's our job to help link the family or come up and brainstorm an idea on their family giving project that correlates to the issues that they were facing at the beginning of treatment, and now they've made all this progress. And now it flips the narrative from being a consumer of services or a recipient of services, someone who is needing or taking, to someone who is giving back to their community. So a couple examples of some family giving projects, and this is a very structured process for the planning and for the implementation that the clinician walks the family through. But a couple examples are a family that had a group of teenage boys who are essentially terrorizing the neighborhood, property destruction, vandalism, a lot of breaking and entering, that sort of thing. And their family giving project was to organize a community cleanup day where they made flyers, they bought the supplies, they recruited people in the neighborhood to go around and beautify, clean up their neighborhood. And then when a family is able to go back and look at that, and the children see their caregivers lead them through that process, it fundamentally flips the paradigm of what this family is upside down. When they are able to see how they can positively impact their neighborhood or their community, it's very, very powerful. And it demonstrates a way to become powerful without being destructive. Another example is a family in rural Indiana that raised rabbits as a staple livestock, an item they would eat. They were so destitute, so impoverished that they had to raise rabbits to sustain themselves. And there was another family in their neck of the woods that was even more impoverished than they were. And so their family giving project was to give them some starter rabbits, for lack of a better word, and train them and educate them on how to raise rabbits so they could have their own sustained food source. So that might be a little macabre for some folks liking. I like to mention it because it sticks in your mind. And if you think about sort of the end product there, they are helping a family with a potentially life-saving skill. They're providing a life-saving skill to another family. And the takeaways that the individual family members have from those experiences almost makes everything else that we've done with them as clinicians pale in comparison. They've done it themselves, and everyone gets to recognize that. So next, I am going to pass it on to Janet to walk us through training and implementation.
I'm going to move forward. Thank you, John. Hopefully you guys can hear me all, or can all hear me. So as John just talked about the FCT model and the 4 phases of treatment, I'm going to talk a little bit about FCT as more than just that clinical model. When we implement FCT with an agency, or an agency chooses FCT to be implemented, it's also a management model. And we're going to talk about what that means, but those two run parallel together through the implementation of FCT. The first thing is situational leadership, and we use situational leadership from the Center of from Leadership Studies. And what this really means is that the supervisor changes their leadership to address task behaviors of the clinicians, and to develop and change that clinician's behaviors or skills. The next is peer supervision. We actually use peer supervision in our weekly team meetings, and this promotes accountability and support and hope, peer feedback amongst peers. We see that develop over a period of time, from a regular team meeting that happens on a weekly basis to high-performing teams where the supervisor or leader has very little interaction because the team becomes self-supervising. The organizational culture is also impacted by FCT, as we see in some agencies, FCT may be only impacting a very small component, but however, as the leadership develops and adopts pieces of FCT, we'll see that begin to change, how the organizational culture changes throughout time. So you may have a team process, a peer supervision process within FCT. We come back a year later or 2 years later, and we're seeing those things integrated into their other program sites. As I talked about the team primacy component, we believe that that weekly team meeting of support and accountability is really the administrative priority of all members. That's where team members come in to get their buckets filled. That's where they come in if they're feeling hopeless, but they are hearing small successes from their team members, or their team members can talk about how the changes that have been made within other family systems helps instill hope. And one of the anecdotal things that we know is when clinicians exit agencies, the one thing that they talk about, the reason that they stayed as long as they did, is that team and that connection that they had amongst team members. So this definitely has a direct reflection upon staff retention. Data-based decision-making, we at the foundation collect fidelity data, we collect data on training and supervision. We collect any external data that may need to be collected from external resources, and we use that data in a feedback loop to either provide different leadership or different interventions with agencies, and agencies use that data amongst their implementation teams to make any changes necessary to adjust what's working or not working. And that works in a cycle. So we don't use just what we think we see, we actually use black and white facts based on the data. Customer service, and our customer is our family, or our customer is the agency that contracts with the foundation. But from a agency standpoint that's implemented FCT, their customers are meeting the family needs, the stakeholder needs, and their community needs. So not only do we have this clinical process, we also have this implementation process for FCT, and those two work together. As you can see the arrows on the slide that goes back and forth, it's not just we implement and move forward to the clinical process, it's a process that goes back and forth over time. Our implementation process, we'll get into in a little bit, but we use that readiness assessment, we use our FACT, which is our Fidelity Adherence Compliance Tracker. We use our implementation tool, FCT implementation tool, which we call a FIT, and we use our IDA, which is our implementation driver assessment information, to drive our reporting for our agencies that help drive strategies or a treatment plan for agencies to continue to implement and improve their FCT implementation over time. So training and certification, we utilize an online platform through MindFlash, which we call Wheels of Change. It's an intensive 90-hour standardized training process that all clinicians and supervisors go through. It's a competency-based program, which means they go through units and then have to pass a test on that particular unit before moving forward. And for this particular case, in addition to that, they also have 16 core checkoffs. So they have to demonstrate the competency in the field to be able to become FCT certified. So they go through a unit, for example. They may take that unit and practice it either in role-playing team or in supervision with a trainer or even with families in the field. And then they actually videotape or have someone go in the field with them and watch them actually implement that particular piece that they're working on. And then they'll either pass that process or not through a checkoff process. Most of the time, the first go around, we see clinicians not pass, but through feedback and coaching and future attempts, we'll see them eventually get through all of their 16 checkoffs and they become certified. Once they're certified, that certification lasts for 2 years. And then the next level up we have, which we call level 2, is a train the trainer process. We encourage agencies to identify staff early that are demonstrating the ability to give feedback and be direct and can have mastered the core skill areas and have their FCT certification. We train them on a trainer process with inter-rater reliability. And then we have what we call level 3 certification, where a person is a trainer and they're able to train supervisors. And then we have the FCT supervisor certification, which mirrors in some ways the FCT certification, where they go through an online course. They actually have checkoffs to complete, again, with inter-rater reliability, and then they become FCT supervisor certified, and that is a 5-year certification process. Our goal is for agencies to become self-supervising, where they develop their own trainers and they develop their own supervisors, they develop their own master trainers to be able to provide this within the agencies over time.
And Janet, if I could clarify, the supervision certification is good for 5 years. It doesn't take 5 years to reach that certification.
Thank you, John. So each FCT phase requires specific fidelity interventions and documents that demonstrate process of action. So one of the things that makes our model a little different is that the family drives this process, not a specific time frame. So just because a family's been in service for 30 days or 60 days doesn't mean they're going to move to that next phase of treatment. But what it does mean is that they have completed pieces of fidelity documentation that demonstrates to the family and demonstrates to the clinician that they're ready to move to the next phase of treatment. What we measure is that those fidelity pieces within our model are completed the same across the board. So that if you were to go to an FCT agency in Massachusetts, or you were to go to an FCT agency in Los Angeles, you would see our staffing process looks the same. You would see that the fidelity documents that are due and joining an assessment look the same. We strive to not have any drift happen in our model. And if we do see drift happening when we do our agency reviews, we put corrective measures in place as soon as possible to get that agency back on track. We use electronic health records within the agencies that we work with to track our information and to track our fidelity documents. We still have agencies that are still working in a paper format where they're tracking everything through paper, but most of our agencies have now moved to electronic information records, and we're able to track that information through data pools. We can sort that information as an agency. We can sort that information by state, by agency, by clinician, and by each family itself, each client. Thanks, John. So there are 15 individually designated fidelity documents that we look at. There are specific ones for each phase of treatment. Each clinician is trained on those fidelity documents. Each supervisor are trained on those fidelity documents. And the supervisor also has fidelity documents that are completed in FCT-specific phases that help the clinician identify and move a family through the phases of treatment. So implementation of the model itself, it begins with us with what we call a RAM, or an FCT readiness assessment matrix, that's completed after review of documents. It's after review of an application from an agency and actually meeting with the agency. And then once that's completed and an agency is kind of good to go, we've recommended them to implement FCT. And it's a process for an agency to go through to be able to make the commitment for FCT. Once that happens, we make a recommendation to our foundation board, and if they're granted permission to move forward with FCT, then a licensure agreement happens with those agencies. Once that happens and we start implementing FCT through training, oversight, modeling, etc., then we complete what we call an IDA, an implementation driver assessment, and a FIT, an FCT implementation tool, every 6 months with an agency. That just provides them with where they are, how are they doing. And initially, we complete that information for them or with them, and then by the time we've been working with an agency over a period of time and their implementation stages change, then they're actually able to complete those documents and provide those to us for review and oversight. The Fidelity Adherence Compliance Tracker, we call that the FACT, that collects on a monthly basis and is provided to our agency active clients that are getting services and the time frames that that are required through our licensure process. For example, contact with families after referral. Are they completing joining and assessment? How, are they meeting the minimum treatment intensity with families? Are they making it through the phases of treatment in desired time frames? And if any of those areas seem to be off, then we can intervene strategically and intervene quickly to make changes as we need to. Once a year, we provide a licensing report to our board and to our agencies. And really what that is a program review of how implementation is going. We look at everything from daily service notes to treatment minutes to our family-centered evaluations to our clinicians getting through the training and the desired time frames. We provide all of that in a report so that the agency has it, but also if any external monitoring bodies want to see that, they're able to see how implementation is going through that agency. Through these pieces, we are able to replicate the fidelity of our model and replicate implementation of the model within agencies that desire to implement FCT. John, you can move forward. Oh, and through all of those things, that's where we get, I'm sorry, John, if you'd go back, that's where we actually get gainful outcomes. We're able to see that the families are meeting the goals, the families are moving through desired phases of treatment. Agencies are moving through implementation phases as well, and we're able to see those outcomes that we want to see with families, where children are staying with their families or successful unification is happening. So the foundation worked with NERN, the National Implementation Research Network, and the Global Implementation Society on our implementation process. There's 6 phases of implementation: exploration, installation, initial implementation, emergent implementation, full implementation, and innovation and sustainability. We take that information, and in our IDA, our implementation driver assessment, we look at cultural competency, organization, and leadership drivers. And every 6 months as we go through that IDA with an agency, we're looking at progress made, pieces that have been implemented, areas that may still need further development, and we strategize with the agencies to be able to move those to the next in place on the driver, so that we can help and assist agencies move from initial implementation or installation to emergent implementation. And then the implementation teams is a huge part of how we implement FCT within an agency. It's important that we have buy-in from the top level of agencies to the clinical staff that are going to be involved in FCT, that it's not just something that someone has come in and said, plop, you guys are going to do FCT, that we really need excitement and a buy-in and investment from the companies that want to, or agencies that want to implement FCT, or counties that want to implement FCT. And so we involve them on the implementation team. We involve them on regular meetings that need to occur that celebrate what's working with FCT implementation, and also create strategies about any areas that may need continued development and get them involved. And when we get those cheerleaders within the agency, that's where we see implementation take place and move along more steadily than we would if we don't have those cheerleaders and we don't have those buy-in. From our QA, QMS staff, and HR, everyone has a stake in the success of FCT and implementing it within an agency. So there are some key licensure standards that we look at when we're working with agencies. One of them is the clinical certification and training. Organizations are expected to achieve these benchmarks within a period of time for their clinician and supervisor and trainer certifications. There's fidelity and adherence. We have minimum thresholds that we expect agencies to achieve and maintain these benchmarks as it relates to fidelity and adherence. And we have outcomes and measurable benchmarks that, again, we expect and have expectations for. Again, with all of this assistance and coaching and modeling from the foundation. And then there's the implementation process that we, again, want the buy-in. We want the commitment from the executive management team to the clinical staff on implementing FCT. So the path of FCT or implementation, someone submits an application to the foundation, but how it gets to us initially is through someone's done a literature review and FCT has come up as an evidence-based, community-based model, or there's been a previous clinician that has experience with FCT, or there's been exposure to the model in the community. They submit their FCT application, it's reviewed by the foundation. We determine within the foundation if it's feasible to move forward with a readiness assessment with an agency, inclusive of all costs to the agency, and if they're able to financially implement, but also if the agency's ready to implement. We conduct a readiness assessment, which covers all of those areas discussed above. That's meeting with all the key stakeholders within the agency and external stakeholders. That's HR, QM, clinicians, directors of clinical services, et cetera, and assessing why they want to implement FCT, assessing if they have the ability and the foundation to implement FCT. And then from there, we move to the review of scope of feasibility. We present that RAM, that readiness assessment, to our board with a recommendation to move forward with FCT. And then we license an agency. And then the last thing is we launch FCT implementation. That process can move very quickly sometimes, and sometimes it takes a little longer depending on where an agency is over their buy-in for FCT implementation. What is our intent? Proven research services that can be replicated through a nonprofit system, large scale implementation systems. So one of the, let me say this a different way. One of the things sometimes that happens is that an agency decides to implement FCT because they have to implement an evidence-based practice, or they feel like it might be best to implement an evidence-based practice for payee reasons or payer reasons, and they're doing it because it's task-driven, not because it's value-driven by their values meet with the FCT values. And so that's one of the issues that to get sustainable results is there has to be that value around the implementation of FCT and wanting to implement FCT to be able to have that sustainable outcome of implementation and the long-term work that it takes to implement a new model or an evidence-based model. Okay. So FCT consultants, that's okay, go ahead. So FCT consultants, each organization is assigned an what we call a program consultant, and their role and the role of the foundation is to help move organizations through the stages of implementation to achieve full implementation of FCT. The program, what we call program consultant directors or PCDs, provide on-site and off-site weekly contact with agencies. That on-site might not be weekly, but they definitely have contact on a weekly basis with our agencies. They have contact and model and coach supervisors and organizational trainers. We provide case consultation and staffing support through their weekly team meetings or through supervision consultation. During supervision, review of videotapes or face-to-face supervisions we provide, and we model that supervision, and then we coach and practice that supervision with a clinician, with a supervisor. We monitor fidelity and adherence to the model and provide that feedback to agencies. We set up systems within organizations to self-monitor, so if there are QA issues that need to be, or QMS issues that need to be monitored, we want the organizations to begin picking up that monitoring process when they're at that stage of implementation and provide feedback to us about what they see that is working and not working, and then we're providing oversight to that whole process. We go into the community, provide education around FCT or stakeholder training and consultation. We may partner to do that. We do that annually at our FCT National Conference, and we coach and model agencies as they develop the ability to go and market or educate on FCT within their communities. We establish service standards to reflect current needs and sustainability. So as states go through transitions or transformations, we are revisiting and supporting and advocating that FCT standards are met, and that we also help agencies know which standards that always the highest standard within the state is the standard that the agency is to meet, and how that might mirror or crosswalk or integrate with FCT. And then again, we do our implementation driver assessment on a biannual basis, and we do our FIT, our FCT implementation assessment on every 6 months as well.
All right, Janet, thanks. I'm going to move this on to outcomes, and I'm going to go through this a little quickly. We're going to provide all this information to you all. If you have questions and want to drill down on some of this outcome information or anything that we discuss. We're really going to encourage follow-up conversations. We'd love to connect with you after this to have those conversations. One quick thing I wanted to mention that Janet spoke about, it reminded me of when FCT was first implemented in the organization where I was working as a clinical supervisor. One of the things I really liked about it was that field-based competency training. And I apologize, there's a lightning storm going on, so I apologize if that's coming through the audio. But that was such a fresh of breath air to know that my clinicians are being trained to that degree and we're having to go out and demonstrate the skill. And what implementation science teaches us is that if we go up and just melt brains with didactic training and PowerPoints like we're doing to you guys today, there's about a 5% transfer of skill in the field. But when you provide the didactic information in classical training, plus monitoring and practice and then coaching in the field, that jumps to 95%. So that was, I saw it had a massive impact on the competency, which then leads to confidence in clinicians, and particularly with younger clinicians, being able to see their direct influence and impact on the very difficult families they're treating goes a long way to boost that confidence, which also keeps them in the field and keeps them in the agency. So we're going to start here with some national data looking at demographic in terms of who is served or who's making referrals. So vast majority of cases being maintenance referrals. In some places, we're seeing that trend change and become more reunification. I think that is you could overlay that where in pockets where there are severe opioid epidemic is really gotten its roots into the community, where a lot of kids are being pulled out of the home. You see reunification rates of reunification referrals be a little higher, and then pretty expected breakdown. A lot of the referrals are coming through social services, so that's child protective services or even foster care, for example. Managed care organization and behavioral health is sometimes one and the same, but that's basically referrals for behavioral health reasons. And then juvenile justice is also represented there at 19%. A lot of this data may be skewed by Indiana, which is one of our largest states and is serving the most families because that's a contract specifically with their Department of Children's Services. And therefore, by the nature of that design, the referrals are coming directly from child protective services, foster care, that sort of thing. Next, we're going to look at some prevalent presenting issues. So these are issues that were identified both at the time of referral, but also this information is collected at the end of treatment. And so, by now the clinicians sort of know what they were dealing with. And it's very telling when you look at this that we have a ways to go when it comes to developing our trauma-informed workforce. You're going to, meaning that the 10% of the families here rated as having trauma as part of their reason for referral or an issue that was discovered through the course of treatment is extremely low to reality. So this slide, I feel, is very inconsistent with the reality, and that's exactly why I'm showing it, is the need for ongoing education and work on highlighting the importance or the prevalence of trauma. That's a big initiative that we're taking on at the foundation and weaving that into our consultation and implementation of SCT. Interestingly enough, you're going to see a very similar slide from the LSS group, and it's going to show a more accurate representation. So some broad strokes of our 2017 annual outcome report. We're still working out and cleaning up the accuracy of our data for our 2018 report. 88% of families achieved a successful outcome. That essentially means that they were successfully maintained or reunified in a non-paid caregiver home. So that could be a kinship care, that could be Aunt Jane down the road, that could be some friends. Basically they were kept out of institutional care, and that's the primary objective of the SCT Foundation and of SCT, is that we keep kids in families. 97% program completers achieved a successful outcome. So that first number is all referrals into FCT across all programs nationwide. And then if we only look at the families that completed treatment and achieved their treatment goals, that number jumps to 97%. So that again goes back to the importance of engagement and being able to keep a family through the course of treatment. 96% of families that were referred into FCT were successfully engaged, and 88% report FCT improved their family life. That's a self-report measure that we include in our discharge data summary. This information is taken from a family satisfaction survey that we give all families to complete anonymously. At the end of treatment, they're given a link to go to a SurveyMonkey survey, or they're given a paper copy to complete and then mail in to our central office. And as you can see here, very good ratings in terms of the family's direct anonymous feedback on services. And again, this is all referrals. These are all clients that were served. 633 families from 2015 to 2018. This is a snapshot of Indiana specifically, and part of the reason why we wanted to show this is that this shows a stable, well, let me back up. We implemented in 2014 statewide in Indiana. I believe it was early 2014. And this is looking at data from established programs that are 2 years, 2, 3, 4 years post-implementation, because we expect those results to really show themselves after year 1 and particularly at year 2. This is also jumping back into the implementation science conversation real quick. Our approach is that we want to work ourselves out of our job as the program develops. So we have we have multiple train-the-trainer tracks, levels 2 and level 3, to where we find that champion during initial implementation for FCT in that organization, and we put a lot of energy and effort into training that person up so they can essentially take over the majority of the things that we do at the foundation during early implementation, and we transfer those skills to them so they become self-sufficient and autonomous, and we move back more into a monitoring role and help with things with more 30,000-foot objectives like program growth, additional funding sources, that sort of thing. That's our role shifts during the implementation cycle. But as you can see here, very stable, very good outcomes over that 3-year stretch. Around 100 plus families that we're looking at here. And these are just program completers. And then same thing, that same time frame, same population, looking at that self-report measure of did FCT improve the family life. Again, very stable and positive outcomes there. And the reason why the family's perception of treatment is important is that there's actually there's a movement currently on really deciding who gets to decide or coming to a consensus programmatically and within the system of who gets to decide when treatment was successful. Does the family get to decide that, or does someone else get to decide it? And so we kind of take a balanced approach, but we want the family's voice to be very loud in that process. And there's also evidence to point that a person's self-perception of change and progress has a stronger correlation to long-term outcome. In other words, if a person feels or thinks that they made progress, they begin to act in accordance to that. So that's something we definitely want to reinforce in our work with families. This is a summary. This is a explanation of some studies that are currently going on in Indiana, given that it was a statewide agency. A statewide implementation. And basically they took all the FCT families and they matched them with another group that was getting an array of multiple different services, but they matched them in terms of the acuity of the family. And the results of that were very promising in terms of faring better. The FCT families faring overall much better. The cost of FCT was higher for children participating in FCT. For that second bullet point, however, something to point out there, while the cost was higher, had still long-term better outcomes that will continue to combine over time. But also there was a bit of a flaw in the study that the principal researcher noticed when we were meeting to discuss this data, that when they compared the cost, they only looked at FCT, of course, for the cost, but when they looked at the control group or the comparison group, they only looked at the identified client's services. They did not account for all the services that everyone in the family was receiving, which is sometimes everyone has their own individual therapist. So one family could have 4 or 5. With FCT, oftentimes, because it's a comprehensive model that includes both individual and family work, oftentimes those other services are put on hold. And therefore, there's a pretty significant reduction in costs when you look at it that way. Well, that's what the theory is, which will be tested in the study. The FCT kids were more likely to remain in the home during their involvement with services, as well as be reunited in shorter time frames. And family functioning scores on the CANs for those in FCT increase at a significantly higher rate than those in the non-FCT group. And these I'm going to really skim over fast. These next couple slides reflect a study done by the University of Maryland, which is a long-term study over 5 years, and comparing outcomes for juvenile justice clients, one group receiving FCT, the other group going into a group home. The FCT group significantly lower rates of conviction and incarceration in the adult legal system. Initial intervention cost of $30,000 less, post-treatment costs more than $41,000 less than the group home group, and those lower costs persisted 12, 24 months post-admission. And those, in other words, those costs remain low over time. Furthermore, 1 year post-treatment, FCT youth had less frequency and proportion of residential placements, days in pending placements, and days in community detention. And the bottom line financially is that the total estimated savings for the state ranging from $10.9 to $12.3 million over a 4.5 year period, which is not why we all have our hearts in this game, but it certainly helps us sell this model to the people with their fingers on the purse strings. Next, I'm going to pass this on to Ann and Emily from LSS of Wisconsin and Upper Michigan, and they're going to now take it away. Thanks, guys.
Thank you. So LSS of Wisconsin and Upper Michigan is our broad company. This program, the FCT program that we're talking about today, is operating out of Eau Claire, Wisconsin. We're in the west central part of the state. And there were several factors taking place around the time that we began providing evidence-based practice out of our office. We had been providing in-home family therapy for over 22 years. However, the growing need, the intensity of the families, the juvenile justice population was growing, and one of our stakeholders, one of our partners, reached out to us and said, hey, can you guys work with us to bring an evidence-based practice that's going to specifically target a lot of the juvenile justice population? And we worked with them and began providing MST, multi-systemic therapy, at that time. Another factor that was occurring at the same time was a method of treatment and a funding source called CCS, which is Coordinated Community Services, which really was a client-driven movement. So the client is really driving what services, what their needs are, and the funding source really opened up the door for us to be able to provide a highly specialized model. So we had started MST. That target population, however, were 12 to 17-year-olds. And very quickly, the counties that we were working with, about 10 to 12 of them, were asking us, yep, but we've got these 9 and 10-year-olds that are coming up, and we really need to be able to be providing services to them as well. And MST also had more exclusionary criteria than FCT did. So before we could accept a case or a family, we had to go through this long list of things that would make them ineligible for the services, including the age of the kids. And the counties were becoming a little frustrated with that. We were becoming frustrated because we were just not able to reach as many kids as we had need. The MST practice didn't involve the trauma components. As a matter of fact, if we were, our other in-home family therapy program provides significant TFCBT, trauma-focused cognitive behavioral work. But if we were providing that already, the MST model would require us to actually stop providing that for a period of time to do the MST model. It's very behaviorally based. So dealing with kind of what are those behaviors at that time as opposed to what was driving those behaviors. And so as we were providing this and our counties were sending us referrals, we found that we were running into roadblocks to being able to serve. And so again, working with our county stakeholders, they said, well, let's look at some other options. And another county that we don't provide service in here, St. Croix County, who is also now providing FCT, had been looking at this. And so we were all working together to find a way that we could meet the needs of more kids, more families, and FCT was the model we really began researching. That all started around September of 2017, maybe a little bit earlier, as we were coming up against all of those roadblocks in the previous model. So we worked, we talked, we collaborated with St. Croix County, with the other counties that we were working with, and made the decision internally that FCT was the way to go. And we reached out to, of course, the FCT organization had begun doing that through this process. And I believe our first official commitment to pursue this was in November of 2017. The lead county for the CCS consortium that we work with had also had a grant at that time, and they were willing to partner with us and help us to launch FCT by funding part of that launch process through the grant. So I think the next slide is the path of implementation that Emily put all of our dates on. So as you can see, submission of FCT provider application and determination of feasibility was occurring about November. We had already completed the initial inquiries in that process. We then launched into the readiness assessment, which was a very exhaustive and, for me, quite an enjoyable part of the process to determine, to show FCT that indeed the LSS organization was capable. We had all of the infrastructure and such that we would need to be able to do FCT within our organization. And so we went into that and had our readiness assessment on November 29th of 2017 when John and Tim came, and we had such a collaboration within our organization as well with our PQI team, with our human capital, with just all of the various components of LSS. We had many of them on the phone with us at various points during the day. We had our stakeholders on the phone with us during that process to go through everything that we needed to do to determine whether or not we were ready to go. And then on Christmas Day, that was an interesting statistic, I guess, that we found as we were going back and looking at this. John notified us via email on Christmas Day that indeed we had gotten board approval, that LSS was going to be able to move forward, and we were surprised at how many emails went back and forth on that day. We were all very much waiting for that word, so that was kind of a funny thing. I had forgotten that we were working on Christmas Day. The licensing and contract completion then took between December and March, with things going back and forth for signatures and making sure that we had all of that in place. But even though that was all was going on and we hadn't actually had the signed license and contract, We had our supervisor start on January 29th. Her name is Emily. She's presenting here today. She had been with us as an MST provider, a therapist, and then she took over the reins as the supervisor, and she launched the first family on February 9th, 2018. I'm going to hand the next piece off to Emily to talk about.
Yeah, absolutely. So during that first process, and I'm going to kind of go quickly here because I do want us to get plenty of time for Q&A at the end after you've listened to us for this long. So during our first part of the process, we were able to build a team first with our internal candidates that we had, and then we were able to slowly kind of add on. Our first year experience was, it was a very intensive model. All the things that we've talked about the first part of this webinar, very much true. But the support through it, the learning that you go through, just the training process in itself was very comprehensive and supportive. So things we learned in that first year, it's also being able to identify, okay, which therapists are the best. So we did experience some turnover in that first year of people deciding, hey, this isn't the best fit for me, which in the long run has really helped us to serve more families and have clinicians that are really committed to both FCT and to helping this population of families. So we were able to gather some of our information from just 2019 thus far, and we wanted to kind of give a comparison to some of those stats that we had shown earlier. So like John said, one of the biggest highlights here is 100% of our cases have been identified with trauma within the family, either with the child that is identified with us, but then as we work with the whole family, a trauma component has come to light with some of these families. A lot of ours are mental and behavioral emotional health, and also some CPS cases as well of children who may have been removed from the family, and then we are working with that family to get the child back into the home. For our next one, again, engagement is a huge piece of the FCT model, and within our 2019 stats of the families that we have closed out, we have had over 20 contacts with all the families that we have worked with. So 100% on that side of it. For our status at discharge, again, it kind of talks about, I think part of this also kind of signifies some of the referrals that we get, but a lot of ours have been placement prevention. So we've been able to maintain that placement with the family of origin or other identified non-paid caregivers. Otherwise, it was maintaining an out-of-home placement for the safety of the child. This next one that we have here is, again, kind of that breakdown of status at discharge. So we have a successful discharge status, so that is maintaining that, either maintaining that placement or keeping them in the home. So we have from all of our, on the left-hand side is the bar for all of our clients at discharge, and then on the right-hand side we have program completers. So of the families that completed the model with us, we were at 100%, and then for ones, that other side looks at more of if we either had some non-starters or a family that for various reasons ended the program with us before completion. The next one here does a breakdown of primary behavioral goal attainment. And this one, again, I'm not going to read it all to you, but being able to show, and my color coordinator, being able to see which colors are which, but gives the breakdown of the report from the families and the clinician on, we range from a slight improvement up to significant improvement with our families, and that's taken from both the clinician report and from the family report. So again, being able to give voice to the family's perspective is very much important, and usually our families, it looks a little bit, I think, different on this one, but usually it's our families are rating very highly the improvement that their family was able to make through the time that they were with our services. And then I think the last one I have, the last stat that we have on here is again asking that question to the families at closure of, has FCT improved my family's life? And we are at 83% of our families stating that they agree, or 17% saying strongly agree at this point. And again, these numbers are taken from our 2019 outcomes thus far. So from our very early implementation, again, we started very end of 2017 to now, we have grown our team with myself as a supervisor, and we are up to 5 therapists. And we are serving all the counties that are highlighted blue on the state of Wisconsin there. So we cover a large portion of Wisconsin up there, being able to serve families in rural areas, and really being able to meet the needs and adjust. That was one thing that when they're saying that each program is kind of specific to the clients that you're serving, that was something that I think we all kind of learned and grew as we were going through the implementation process, is how do we serve these families that are sometimes in very rural settings, and how do we help bring the fidelity of the model to those needs. And then very recently, we have been working in the southeastern part of the state. We do have 4 counties that have committed to launching our second LSS team. And we are set to go with that commitment, and we are working with the budget and everything, and we should be starting with them by the end of 2019. So having a second team running within the LSS company. All right, and I am going to hand it back off. I believe I'm handing it back to Tim here.
Great job. And I'd just like to point out that we do not make our employees at the foundation work on Christmas Day. That was a voluntary email. that choice. I didn't realize that was the day, but good to know. For the interest of time,
thanks for that, Emily.
I'm going to walk through a couple of just interesting projects, and I know FFPSA was a topic of discussion. That in and of itself we could probably discuss for a number of hours, but I'm going to hit on some of the salient points about what we're doing as part of the FCT model, the collaborations, and where we hope and think that that's going. But I wanted to touch on a couple of things that are happening from the research side of things that are important. The first and foremost is the first randomized control trial that's happening as part of FCT that was funded by the Duke Endowment of the Carolinas, and the research study itself is being conducted by the Duke Center for Child and Family Policy in North Carolina, as well as the Robert Margolis Center, who's doing a cost-benefit analysis study as part of the randomized control trial. This study is really important for us in that it would be the highest and most stringent criteria of research design that the model has ever been able to undertake, so we're really excited about it. And RCTs, frankly, are extremely expensive to conduct and perform. So the funding to be able to do this from the Duke Endowment has been great. And we are currently in that RCT now. We are expecting some of the initial results probably within the next year or two as part of the initial cohort of information, with the final study being completed in the next 4 years. So it's a pretty large, it's a pretty lengthy study. Something else that's really interesting about it is that it is being conducted with families and individuals in North Carolina who receive Medicaid funding as their primary insurance. And so it took us a full year in working with the state, working with the different funders, working with different payers, just to be able to get through the rigors of being able to set that up. So again, we're really excited about that to tie into the numerous other studies that we've been able to get published and put out there in collaboration. The second one that's occurring at this point is an FCT trauma-specific research study that's being conducted by Dr. Charlotte Bright at the University of Maryland. This ties into a little bit of the next slide I'm going to talk about, which is our SAMHSA funding for specific trauma research and trauma treatment development of the FCT model and expansion of that trauma treatment as well. I just wanted to acknowledge the Family Centered Recovery Project that's also occurring in North Carolina was also funded for the provision of that by the Duke Endowment. And specifically, that pilot is targeting and working with individuals and families who have been affected by specific substance abuse diagnosis, and even more specifically, large tie-ins to the opioid epidemic that North Carolina was certainly not immune to nationally. And then the final piece where we can talk about with what's ahead is FFPSA. So I'm sure many are familiar with what's going on with the federal initiative to frankly transition Title IV-E funding to Family First Provision Services Act, which received bipartisan support and is starting to implement now, although a lot of maybe a slower pace than what was initially released and designed. there's a number of things that are happening with the FCT side of things related to FFPSA. The first and foremost is that for the open and public submission of calls for model review, we have had at least 4 states submit on our behalf, and so we are somewhat hopeful and anticipating that the summer of 2019 open enrollment submission will get acknowledged by the clearinghouse to begin that review process. The initial cohort of models that were reviewed are up on the clearinghouse now, and it had a number of people kind of head scratching, including us, how they reviewed that, in that the initial correspondence indicated that all 11 of them would go through as well supported, and that wasn't the case. So we are doing a pretty deep dive internally with the handbook that was released by HHS to determine how the clearinghouse is actually reviewing for rigor on these models, and it's pretty stringent. We're pretty familiar with the different clearinghouses, California clearinghouse, NREP, the FCT model is listed on, and the handbook that HHS put out has some of the highest study rigors that we've seen put out by a clearinghouse so far. So there's a lot of work being done on that end. And the other part that ties into the handbook as well as submission process is guidance from ACF as well as the Children's Bureau have issued calls for transitional payments by states. Because of some of the delays in the clearinghouse being adequately be able to review all the different models that the states were requesting, there's currently a transitional payment plan that the Children's Bureau and ACF have put out there, where states can self-review the models that they would like to implement. They need to independently and rigorously evaluate those models and then submit back, and the states will get funded for those models until said model is actually reviewed by the clearinghouse itself. So there's actually 2 states that we're working on now, Nebraska and South Carolina, that are in the process and working with us to get this transitional payment review submitted back. The exciting news about that is if one state actually gets it approved and pushed through, any state can follow suit on that attachment B, which is the form submission back that it justifies the independent rigor that the state performed. So there's a lot happening with FCT from multiple fronts on that. The other piece that we should probably mention is John was hitting on the Title IV-E waiver demonstration project that came out of Indiana that was produced by Indiana Department of Child Services. That is a direct tie-in to the types of studies that the FFPSA clearinghouse was looking at, because the targeted outcomes for child well-being, safety, and permanency were the exact same outcomes that FFPSA clearinghouse is looking for. And we had a large number, upwards of 80% favorable effects for that study, and also a large amount of statistically significant effects for FCT when it was compared against the control group, which was treatment as usual, which could include even other evidence-based models that were being conducted at the time in the state of Indiana. So there was a lot there. I'm happy to field independent questions about that. I certainly can't give any guarantees, but we feel pretty good that the review process for the official clearinghouse process should be starting soon. Then the next slide, just highlighting FCT Trauma Series Project. We were really excited in 2018 to become a partner with the National Child Trauma Stress Network and indicated as a network member, and to receive federal grant funding, which is allowing us to really expand on our capacities to do trauma assessment and trauma training to the existing providers for FCT, but also offers us an opportunity to be able to help with funding to deliver to areas where trauma treatment is not currently occurring. So there is, we're just wrapping up year 1, or we're getting into the end of year 1 for this, and there has been a lot of groundwork on trauma treatment best practices and some of the specific trauma assessment tools to really heighten awareness for clinicians and working with families, just how much trauma and adverse effects impact the family system as a whole. Finally, for additional resources for information, this will be up on the webinar once it's recorded. So I welcome anybody to encourage or to take a look at any of the social media. I am not social media savvy, but feel free to take a look. We've been getting a lot of positive feedback on the Facebook postings that just link a lot of specific interventions and trauma-specific interventions for people to take a look at and utilize. And so finally, I'd like to open up. I know we fell a little short of how much time we wanted for Q&A, but I think we have got about 10 minutes if questions and answers. we can try and provide.
We have questions from the audience. To ask a question, just hit unmute, or if you're having any difficulty unmuting, just shoot me a message in the chat box and I can unmute you as well. Maybe people are being shy, or it was just so thorough that there's not any unanswered questions. I'm not sure, but we'll give a couple seconds and give people a chance.
Yeah, that's what we like to tell ourselves. It was just so comprehensive.
It was. So one question, I can put Anne and Emily on the spot a little bit. I know you talked about this during your presentation as well. But if you could just elaborate a little bit on some of the benefits you've seen for family-centered treatment compared to maybe some of the other approaches that you had been using, in terms of some of the barriers or obstacles that it helped you overcome, either internally to your organization with managing caseloads or contracts, or unmet needs in the communities with your community partners, or things like that. Like just some of the additional details of how it compared and how you found it beneficial.
I would say I'm going to start with the clients, because I guess that's always my focus first. We have seen a lot of families that maybe have gone through some of our other models, or families that have been through a tremendous amount of services and have been deemed as unsuccessful in those. We have gotten a lot of those families, and through the work with FCT, through really getting that joining and engagement with the families and really identifying what they are looking for with their goals, we have had several of those families go through FCT and complete the whole program and be successful with those outcomes. Some of them to the point that they are closing out of like either CCS or other services because of the skills they've been able to develop and consistently use in the time that they went through FCT. When they were deemed before as a family that's gone through everything, and they were maybe given to us as kind of like a last resort or like a Hail Mary case. But that's been the very cool piece that we've been able to see, that ability to continue to work with those families and really be boots on the ground and be in the trenches with the families and help them with instilling some hope and that dignity and respect piece, that we set the expectations high, and the families absolutely, we've had several families say that this is different than any service that I've ever done. And I attribute a lot of that to that joining and assessment, and we really are taking kind of the back seat and learning from them. And that's different than a lot of the programs that they've had experiences with.
And I could speak to the sustainability of this program with the no exclusionary criteria, or virtually none, and the broader age range of clients that we can serve. We have, unfortunately, for most of the first year, had a wait list of families, sometimes up to 16 and 17, but we hired very carefully. We went through the process slowly enough to make sure that we were able to be providing this treatment method with to the best of our ability and hiring the right people. So we have now gotten through many of those Hail Mary cases that the counties gave us early on, and got through those and worked with those successfully. And we're now at a point where we've been able to grow the team and have a very solid team that is so united and works together and supports one another. And we are able to start tackling some of the families in some cases where it's not the end of the road for them, but more we're getting in before it gets to that point. So it's really an exciting time for us, and it's the model itself, the support that we have from from FCT, from John, has really been outstanding to be able to be at a place where right now we are sustainable and we're successful.
Wonderful, thank you. Any other questions from folks in the audience? Okay. One other last question that I had was in relation to working with the, different states for the transition payments for the Family First Act. As they're kind of needing to do that independent evaluation piece, are you finding that they're able to gather the information from the different studies that you've done and meet those rigors that it seems like the clearinghouse is asking for, that they're going to have to provide in order to qualify to get those transition payments? Or are there
yeah, it's pretty, I mean, like we indicated, it's pretty comprehensive, but across those states, and especially that's why I tout the 4E study so much, just because it was targeting almost every targeted outcome and nature of the study design that the clearinghouse was looking for. So it makes it a little challenging on some of the studies that have maybe happened over the last 10 years to make sure that you're matching up, not so much from the study design, but from the targeted outcomes perspective, exactly what the clearinghouse is looking for. But so far, we've been able to match up very well with what we think the clearinghouse is looking for. I think in some of our consults with different national groups and some of the groups that we're using to just make sure we're getting up-to-date information on what's happening at the clearinghouse, like I indicated, there was a little bit of head scratching just based on how the initial clearinghouse reviews came out for some of the first cohort of models. But on the whole, and even in talking with some of the different MST groups and other model purveyors such as us, I think most people are feeling confident that these types of models that are listed on California Clearinghouse or listed on MRAP should and eventually land where they need to.
Mm-hmm. And I'm assuming that some of the providers are currently able to bill Medicaid for FCT too. Is that correct? And
yeah, I would say Medicaid is still primarily the majority of funding stream sources for our providers across the country. I'd say in North Carolina, which probably rivals Indiana for the largest as far as number of families served per year, that is almost strictly Medicaid services. We have a few other states that are just strictly behavioral health Medicaid services.
And one of the things that's come up in some of the prior webinars too was a question about the use of like family-centered treatment or some of the other in-home treatment models to prepare youth who are transitioning out of residential care. And is this something that's used in preparation for transition in those cases as well?
It definitely is. And actually, we see a lot of success when we're afforded some time to be able to start working with families or caregivers before the child's actually being able to be removed from the home. We didn't indicate it on this presentation, but one of the pilots that's taking place now in North Carolina is actually allowing upwards of 90 days for the treatment providers to begin working with the caregivers beforehand. So that's actually starting, I think, this month in North Carolina, just to determine if that additional length of time makes any additional help in reducing like the residential care and sustainability of the children from not going back in. But I'd be remiss if I say that the MCO wasn't also trying to take a strong look at the financial component of how much residential is costing the state of North Carolina too.
Mm-hmm. That's a good piece of information, though, for those who will potentially watch this recording, because a number of our members provide residential care as well and are always looking for more ways to shorten the length of stay and successfully help the youth transition home to family and then be able to remain in the home. So that's helpful to know that that's a pilot that's being offered. One of the other things that's come up in some of the prior conversations has been around the use of telehealth, particularly in very remote, like rural areas or in areas where not only is it rural, but there's often harsh weather, particularly in the winter. Has there been any type of pilot or trial use of telehealth with family-centered treatment?
To an extent. So we have, when we launched in Nebraska initially, that was a large part of conversation because the state of Nebraska really wanted us to come in and try and assist with the western part of the state, which was the first time we had gone into Frontier. as a demographic. So we discussed a lot of the telehealth, and where we landed as a company, as part of our innovations committee, is that while we would be able to endorse part of that time to use telehealth to be able to check in with families if it's accessible, we still needed to make sure there was enough rigor for the face-to-face contact, because what you've heard, I think, from a lot of the speakers today, there's so much emphasis on joining an assessment and getting that trust and rapport that we haven't been able to get reassurance that that can happen adequately with this type of population telehealth. So while for things like crisis calls, for check-ins, for some of that, those components, it certainly works. We still want, from a fidelity standpoint, for us to make sure we're hitting that face-to-face.
Wonderful. All right. Any last questions from anyone in the audience? It doesn't look like it. Okay, well, thank you so much, Tim and Janet and John and Ann and Emily. We appreciate you so much for taking the time today to present to our network and to allow us to record and share this information too with those who weren't able to make it. Just very much appreciated, and we wish you the best of luck. Please let us know when your program is approved for the clearinghouse or those transition payments with one of the states as well, so we can be sure to share that with our network too.
Will do, and we appreciate this opportunity.
Yep,
Wonderful.
thank you.
Thank you.
Thank you very much.
Have a great day. Bye-bye.
Thanks.
You too. Bye-bye.